not all that grows in the garden is good for mother and baby. And so we're going to review the problem, and then we're just going to talk through a case, like I said. Cannabis, the prevalence in pregnancy is about 3.9 to 16%, depending on what age group you um, sort of survey. In non-pregnant and lactating patients, it's up to about 43% now in the age group of 19 to 22. It is the most commonly used illicit substance under federal laws. Remember, it's still illegal under federal statute, which is a little bit different than state and local statute. It's sort of the first problem we have is that we have something that is legal in states and local places, but not under federal law, which is kind of interesting. The first thing that ACOG actually points out is that, and I did not know this because we use marijuana fairly frequently, but in some areas it's considered fairly racist and xenophobic. And so they actually recommend not using it, and throughout all of their publications have switched to cannabis or THC, tetrahydrocannabinol, just because of there's some connotations in certain parts of the country. So they actually recommend avoiding using that, which I did not know. Um, Marijuana or THC is, and see, I still do it because it's so commonly used, even with amongst our patients, is legal in the United States in 42 states now for medical use, and 24 states have approved it for recreational use now, including the District of Columbia. Um, so in DC, and this is a lovely map of those things. The medical use and which types are used medically and recreationally kind of varies by state. And so a lot of these maps that you can go to on the internet, you can kind of go through and hover over and figure out like what's actually legal too, because there are some differences there and there are age restrictions also. So it's a little little bit interesting, a little bit difficult too. And then whether like how you get them and whether like if it's recreational, like going across state lines can be interesting because it is federally illegal, right? So you get interstate problems there. I found this on, of all places, Wikipedia, but Gallup polls actually show that starting back from the 60s, we're only about 10%, like just above 10% of people, now way up to a much higher number of people, um, kind of have really changed our numbers of how people perceive um, allowing for it to be just legalized. So I think it's kind of interesting how that has changed over time as well. Um, Here are different forms of it, so and what they are called, which I found a little bit more educational in terms of what our patients. I thought the slang terms was actually the most interesting part of this, because you don't necessarily. Some of these are not used, at least to me. My patients just say um, marijuana to me, actually, or Mary J, or joints, or a little bit of weed are the things they say to me, but I don't. So because I'm old, they stick to things that they think I'll know. So, but all the other things are kind of interesting in terms of forms and what things are made out of. It's also interesting to say that some of the things that are considered the sort of the products that are supposed to not have active like hemp products in it that are not supposed to have active THC in them. There's a certain percentage of those that, when actually tested, do actually have active biologic compounds within them. And when some of these are tested, when they test some of the like edible products, that's kind of variable on how much is actually within those too. And so it's not actually all that well regulated. So I think that some of that can actually be concerning too across the board. So it's just something to keep in mind for your patients who may be using these. here's a little bit of idea of how things can be consumed and then onset and duration. THC does actually easily cross the placenta, which is where we get into concerns for fetal well-being. It's highly lipophilic, which is why it easily does cross and reaches both into the fetal circulation and can interact with neuronal migration and brain development, which is where our concern comes in, and can then have concerns for uh, developmental problems with how the neurons and receptors develop, and then throughout pregnancy, and then have long-term effects, obviously, after delivery, which is where our problem is here, is we have something that's legal, um, and then what that means for the baby long term, and obviously um, having a long-term understanding of that. We do know that prenatal exposure is associated with low birth weight and preterm delivery. Um, we know that there is a higher rate of NICU admissions and a higher chance, if I can get this, for that it may disrupt blood flow to the placenta and nutrient transfer. And some of these things are actually the same things that we see with smoking and other things that cause vasoconstriction during pregnancy. And then it's also concern for long-term neurocognitive deficits in children, which probably has to do with the problems with neuronal, with how the nerve cells and the cognitive problems that we talked about earlier. So ACOG recommends universal screening over targeted toxicology. And the reasons for that is that toxicology is not great. And what validated methods, and you do need to, it needs to be standardized. So you shouldn't be like only testing or screening certain people. You shouldn't say like, oh, only if a patient comes in for abruption, or only teen patients, or only patients on Medicaid. This should be every patient who comes in for prenatal care will get screened with a validated questionnaire, because that is the best way. It's like how we recommend screening for things like domestic violence. It crosses all socioeconomic, you know, statuses, and it's not, and it also shouldn't just be for THC use. It should be for alcohol use and other substance use disorders. And you really should consent the patient before screening them. And then if you're going to actually order toxicology, you should consent them for it and explain the limitations of it. And here's some of the actual limitations on it. It's highly fat soluble. If you do a urine test, it can be positive up to 30 days after use. I don't know of anyone who uses hair testing, but hair testing can be positive up to 90 days. Oral fluids may actually be like the best way to do it because it's only positive for 24 hours. Um, Other substances that are legal but not really recommended in high doses in pregnancy, like alcohol, nicotine, and caffeine, we don't actually do any immune assay testing routinely as part of pregnancy screening. So, if patient says that they were drinking alcohol during pregnancy, we don't randomly do blood alcohol levels. If a patient admits to smoking and we recommend cessation, which we do, we don't run nicotinic acid like levels on them. We tell you to stop drinking, like if you're downing, 4 monsters a day, which we don't recommend that when you're not pregnant, but we don't, run a caffeine level on you to make sure that you're, compliant with our recommendations. So why we're doing this for sort of one thing over another is a little bit suspicious. That's maybe my personal opinion, I guess. But why we've chosen one over the other is, rather than we've screened the patients that said that they are using it, that should be good enough. We don't need a test to sort of prove what they've already told us. In addition, once we've done this test, there's a lot of structural bias in healthcare related to how the testing is used and reported. Our Black and other minority patients are drug tested and reported to Child Protective Services at a much more disproportionately higher rate than our white patients. The disparity is driven by the structural racism and clinical bias, and it's harmful to patients. What happens once they are put into the system, um, and it does discourage them from continuing to seek prenatal care. And there can be some mandatory reporting laws that may not necessarily um, benefit the patient. It can actually cause harm. And so our goals really and this says OBGYNs, but really our goals for anyone here should be to help the patient and encourage her, whether you're an OBGYN, a family doc, a midwife, a nurse practitioner, to come seek care and continue to seek care, whether she is using, smoking marijuana, continuing to use heroin. We want to say, like, still come get care from us. This is a place where you can feel safe. We want to help you work through your medical issues, and send a positive message of, like, we want to be your support and help you still get good care. We don't turn away diabetics that um, don't follow a perfect diet or forget to take their insulin. So why do we like punish people who don't follow our recommendations on, um, you know, cannabis use and other things. For breastfeeding moms, cessation is recommended, just like we recommend. They don't smoke around the baby. They don't drink high levels of alcohol while breastfeeding, because it can cross. Same things can happen across as it's lipophilic. Um, Breast milk is, has good healthy fats in it for the baby. Um, we strongly discourage them from using it while breastfeeding. It's not an absolute contraindication. You want to talk about the risk and benefits to them because there's so many good things in breast milk, tons of immunoglobulins that you cannot reproduce in formula. And so things that they can do to reduce the exposure, like feeding the baby most, not having the things on their, clothing, those kinds of things. Um, and then doing the same things to reduce and helping them either cut back or quit altogether are much better techniques. And then our treatment strategies should be centered on the patient and where they are. So things like motivational interviewing, what motivates them to move away from cannabis use. What social determinants of health have put them in a situation where they may be repeatedly exposed. What barriers do they have? What is their social network of support or that drives them into that situation? Do they have other substance use disorders, or are they using it to treat a medical condition because they've not been able to seek care because of lack of insurance or other things? Is there a home visiting program that can support them, or a community healthcare worker? Do they need additional psychiatric behavioral treatments that can help them? There's even this like idea of brief texting interventions from things like their social work, like community healthcare workers, or like peer support things where they just get a nice little text that's kind of like almost like a little cheerleading section of, like, you can do this, you're doing great. And so I think that those like little things that help provide them support along the way can do like such great things for them. Right. I'm going to pause there and see if there are any questions.
It's not a question.